I'm not going to talk about intricate monitoring, the finesse of managing a ventilator, the intricacies of managing a cardiogenically shocked heart, inotropes, or the ventilator. We're going to shift gears right now. And to help you do that, I'm just going to introduce the topic of ECMO. Now that I've got you past the idea of finesse, let's talk about how you power infuse and get somebody better from dying. Now, I've got a lot of things going on. I've got contracts, I've got grants, I've got patents. At this old age, I'm so conflicted, consider me neutral. Now, this all started for me in 1984 when Bob Bartlett asked me to be his fellow. And he goes, Zwischenberger, we're just going to need to figure out a couple of things. Heparin bonded circuits and double lumen catheters. Well, we didn't figure out all that, but soon thereafter, we decided to write the first red book on ECMO. This is the first edition. We're now in the 5th edition. So assuming I can still read, I've tried to keep up with all 5 of them. And this is a synopsis of where we stand. Now, you're not supposed to memorize this chart. What you're supposed to do is see that there's various sundry ways of supporting the heart. Intra-aortic balloon pumps, tandem heart, an Impella that works a little, an Impella that works a little better, and ECMO. And ECMO is essentially veno-arterial cardiopulmonary bypass to support the heart and the lungs when they fail. So let's start with the big picture. There's a consortium called ELSO. It has about 430 centers around the world, and we all voluntarily submit our data. The latest data from 3 months ago shows that over 130,000 patients have been treated with ECMO. And if you look at cardiac support and extracorporeal cardiopulmonary support, or ECPR, emergency cardiopulmonary resuscitation, the bottom line of all the papers, there's about 2,000 of them, shows that adult cardiac support will yield about a 45% survival and ECPR about a 30% survival. Now let's start there. Put those numbers in your brain. 45% for cardiac, 30% if you're having a cardiac arrest, and I run out there, start pounding on your chest, and get the ECMO team there within 30 minutes. Now let's say, well, is there any cardiac support or some heart condition that we ought to just turn and walk away? I mean, heaven forbid, in the front row here, the poor lady drops dead, we start doing CPR, and on her, she's wearing a tag that says, I've got a cardiomyopathy. Should we turn and walk away? The answer is no. We don't have a single label for what we call diseases of cardiogenic shock that preclude the use of ECMO. All of them have about a 45% survival. So that's the good news. That's the good news. You should maintain my initial level of old Joe Clark enthusiasm for every single patient who's dying of cardiogenic shock until you prove otherwise. All right, so let's start with the basics. Any cath lab, any ICU, any cardiac surgeon, any cardiologist, any intensivist can put a needle in the groin, thread a wire, and put somebody on fem-fem veno-arterial bypass. Fem-fem ECMO. In fact, you guys are sitting in Houston. This place is internationally known for their enthusiasm for doing that. Now, here we are. We moved a little ahead. We said, well, sometimes veno-arterial ECMO isn't good enough, so let's add a Avalon or a double lumen catheter to where we can oxygenate the blood in the upper part of the body and still perfuse the lower part of the body. You heard Harlequin syndrome referred to earlier. So that's in 2016, that became popularized, and we all started picking up on that. And don't forget, you have to perfuse the distal limb when you stick a big cannula in the femoral artery. So that's called hybrid ECMO. And now we've become a little more sophisticated, and in the 20% of patients who may or may not have extra afterload in their heart from VA ECMO, we sometimes add an Impella, a Trans-septal Catheter, or an intra-aortic balloon pump. You heard our colleague from Germany refer to the fact that they're getting really wild about the Impella over in Germany, and we have enthusiasm for the balloon pump in some places in this country. But basically, keep it in your mind, about 20% of patients who have cardiogenic shock supported by VA ECMO may need some form of extra support. So there's a picture of the Impella and a Trans-septal Catheter. Left ventricular unloading, you heard earlier, will help the heart tolerate the stress of shock, and will also help unload the left ventricle. So let's start talking about the literature. There's been a lot of literature thrown at you already, but there's over 2,000 publications were analyzed. We had over 4,000 patients, the data was sifted through, and what we found was, well, maybe if we unload the heart, we have a slightly less mortality than if we don't unload the heart. I don't know, that's kind of selective, because when you unload the heart, you've already identified those 20% of patients that may not benefit. So when you look at the actual studies, you show that in 2 major studies, 52% of the patients survived in one and 43 in another, but look at the control group, 22%. Go back to what I told you at the beginning. Across the board, about 45% of patients survive with VA ECMO. So it's a little unfair to use control groups with 22% survival. So does unloading really help those patients? I don't know. So this is an illustration of a left atrial unloading with a Trans-septal catheter. And lots of times a cardiologist will have to mold them in the back of the room and thread them in to go across the septum and get good drainage. And that's really not immediately available right now. I also throw this slide up to show you that many of us who are enthusiasts of ECMO try to ambulate patients. Why? Because if you ambulate, even though you're on veno-arterial bypass, you have normal respiratory mechanics. You maintain vascular and muscle tone. And also, you have better well-being. You recover quicker. So we're doing more and more central cardiac bypass. We're doing more VV and VA ECMO with ambulation. And all of this is designed to help patients recover. Now, I love this slide because Shaf Kashavsky, one of the leading proponents of bridge to transplant, and I throw that up there because if you're in cardiogenic shock and your heart's dead, the next step in the algorithm is a heart transplant. He published this in the 4th edition of the Red Book with 4 choices. You get ready for this? The latest edition has 10 choices, and 2 of the original ones were dropped. So this just shows you between the 4th edition and the 5th edition, the same author went from 4 choices to 10 with 2 of the first ones dropped. That's how dynamic the field of ECMO and thinking is. All right, let's look at some more literature. Postcardiotomy, cardiogenic shock. You operate on a patient, you try to come off bypass, doesn't go well, you slap them on ECMO. You see about a 30% survival of discharge. Not bad, because back when I was doing cardiac surgery, those are the ones that you had to talk to the family, and not in a good way. Okay, let's talk about acute fulminant myocarditis. 11 reviews reports, over close to 500 patients, almost a 60% survival of discharge, and in various reports, 80 to 100% lived at least 1 year. So if you've got myocarditis, keep up the hope, because that's a pretty good group to be in. Let's talk about cardiopulmonary resuscitation with ECMO. Look at the growth. This growth curve ought to be my stock portfolio. Unfortunately, nobody in the room has that anymore, but the point is the growth is exponential, and we're seeing a 30% survival. So if any of you people in the room were to drop dead right now, 30% chance, regardless of the diagnosis, would get you through it. And this data was first generated back in the early 2000s and all the way up into 2013, 14, 15. Guess what? The 2020 data is exactly the same. The good news is we get a consistent 30% survival. The bad news is we really haven't improved on that much. So let's talk about that. One of the good things is over half are neurologically intact after you resuscitate them and get them through all this. So that's a good thing. If you did drop dead in the front row there, 30% chance of survival, greater than 50% chance you'd be okay and be able to ride a bike, drive a car, do other things. So that's all good. But the problem is we still haven't figured out exactly what the right formula is and how to get patients better than that 30 to 40%. Here's ECMO for cardiogenic shock, a big registry report, a big review, 41% in adults. More, 1,500 patients. I'm running through all the world's literature just so you get to see there's a certain theme, but there's also no specific answers as to who you have to unload and who you have to do when. It all depends on being able to have the judgment to start it early when it matters. So in these patients, we had a 44% 30-day survival. An ECMO for cardiac arrest and cardiogenic shock, meta-analysis, another 9 trials looked at. ECMO did slightly better than intra-aortic balloon pump, but there was no difference compared to tandem heart and Impella. By the way, tandem heart and Impella, 20, 30 grand on top of the expensive ECMO. So when you start talking about cost benefit of these different devices, you've always got to kind of think, gee, I'm pulling this trigger. Am I going to pull that one? Am I going to run up the cost? Am I going to have a better outcome? Am I going to really improve on patients' outcomes in terms of their ultimate well-being? Am I going to incur more bleeding? You use a tandem heart or an Impella, you increase the incidence of bleeding. Here's another one, the ELSO database, VA, ECMO, and acute MI, cardiogenic shock. No difference in survival between cardiogenic shock and acute MI cardiogenic shock. So even though we spend a lot of time morselating the different etiologies of cardiogenic shock, it still seems to kind of fall out. Age makes a difference. pH makes a difference. Whether you do ECPR makes a difference. Obesity, longer duration of ECMO, hypotension, certain races. We already know that. We don't need ECMO to tell us that. We know that from the cardiology literature. Okay, what are the complications of ECMO for cardiogenic shock? Well, the top two ones, I don't get too excited about those. If you support the kidneys, they get better. If limb ischemia can be revascularized. The ones I worry about are brain death and a stroke. So that's about 10%. So that 10% is worth worrying about. So we need to be thinking in terms of quality of life in that way. So let's talk about some more. Since acute MI is the majority of cardiogenic shock, you heard that earlier today, let's look at how it does. 45% in hospital mortality, that means 55% survive. So actually cardiogenic shock's a pretty good one. Why? Because you can do other stuff. You can do a PCI and revascularize them. So if you have an acute cardiogenic shock from an MI, often if you can support them, keep them alive, your friendly cardiologist can do a PCI and reestablish flow. Now, why is it kind of messy? Well, it's easy to talk about ECMO as if it's one thing, but look at here. Almost 60% had an additional device inserted with the ECMO, and 30% had an additional device placed at the same time. Is that a pure prep for ECMO? No, but it's thoughtfully adding more and more support or more and more treatment in order to try to get the best results. You heard the panel earlier say we need to work through the individual patients and apply these algorithms that are best suited to their outcomes. So here's a good one. So now let's start talking about septic shock. You heard about that earlier and everybody went, ooh, septic shock. Well, the problem with septic shock is it's very difficult to wrap your head around and know exactly when to pull the trigger for ECMO. Here's a study that brags about a 70% survival. Not bad, right? Septic shock, going down the tubes, throw them on ECMO, 70%. Oops. Here's another study that shows a 15% survival. And if you get a little liver failure, your shock goes too long, you start to get severe acidosis, yeah, you're not going to do so well. So the bottom line is you've got to get the patients on ECMO within 30 minutes of profound septic shock. Now think about that. You're making rounds. You're at the one end of the ICU, the other end of the ICU. The nurse calls and goes, this guy's not looking so good. He's kind of white. His blood pressure's gone down. He's not well perfused. His external limbs are cold. Now, the first question you got to make is, are you going to break up rounds and go see him? Right? Or, worse yet, drag yourself away from the computer writing notes that day and go see him. So you go see the patient. You think on it a little bit. Check the drips. Check the ventilator. Check to make sure the inotropes are still on and everything. Well, you just ate up 15 of your 30 minutes. I'm sorry. You better call your ECMO team pretty quick because they better get up there within the next 15 minutes, or you generate the kind of curve on the right instead of the curve on the left. Okay? So now why don't we go look at the smart people and ask them what the guidelines are? Well, here's where it gets interesting. Inadequate tissue perfusion. Wait a minute now. Did you turn me off? I was on a roll. You turned me off. That's not fair. Where was I?
The rounds and discussion took 25 minutes. You have 5 minutes on.
Well, I was getting to the punchline. Hey, the bottom line is this. The guidelines from the ELSO people is very simple. If you're in trouble, if you're hypoperfused and you're in profound shock, put them on ECMO. If you go to the American Heart Association, if you're in shock, you're getting acidosis, put them on ECMO. And the most important thing is once you get them on ECMO, you've got time to think. Now you can call a cardiologist to see if they need to be revascularized. Now you can check and see if they're septic. Now you can see whether or not they're brain dead after you checked them for a while. The point is, if you don't get them on ECMO in that first 30 minutes, you've missed your window. You've missed your window. So the bottom line is, ECMO's good, decision-making's good, do it quickly.
Thank you. Yeah, you probably have questions.
You're not going to get away that easy.
Yeah.
I thought I told you the right answer.
Before others think of question, it seems like in these days of cost effectiveness, life and death both are getting more expensive. Kids are not coming out without cesarean section. Now people are not dying without ECMO. Who's going to pay for all this? So how do you have an algorithm where absolutely these are the people who will benefit, I'll go for an ECMO, and this ones I'm not going to go for an ECMO? Because it seems like now, every time there's a code, the ACLS protocol has been extended, let's come and do some eCPR and do an ECMO.
Well, that's a good point, actually. It's very tempting to think of ECMO as a Lazarus machine, but it's not. And the most important thing is to very quickly, while you're mobilizing your team or alerting them, to be able to make that 30-minute window where all these data show that you'll get those good outcomes. You've got to quickly say, number one, do they have a prior malignancy? Do they have a prior DNR? Do they have a predisposing injury that they're not going to recover from? Have they had an unwitnessed arrest? Are they potentially brain dead? Have they had a bad, massive stroke? And those are things you can do within about 3 to 4 minutes, is the really bad stuff. And if you can exclude that, and the patient is now the age is a little dicey. They used to say 70. They used to say 65. Since I'm 68, I say 70. But the point is that you've got to have an age limit where the risk-benefit flips. So in our institution, we've got very strict criteria. Over 70, no. If they have any evidence of brain injury, any evidence of unwitnessed arrest, if they've been down for more than 20 minutes, we walk away. It's tough. You got to really have forethought to walk away. But we know that if you put somebody on after 30 minutes of being down or having CPR or having a situation that's potentially unreversible, you've got to walk away. 30 minutes. If you take longer than that, your data is going to go right down the toilet. And then you really do have a cost-benefit discussion. You get 30% survival, I'll argue with any administrator. You get 10%, I won't defend you.
So I'll ask the next question, and I know I'm not going to win any debate with you, but you emphasize that 20% of patients need unloading, right? 20% of patients. You phrased it need unloading, but I would argue that in the literature, 20% of patients got unloading. We don't know the real percentage of patients who need unloading because it's generally not, the need has not been indexed. It's just what has been practiced. So I think that you alluded to some of the meta-analyses that have been done, and there are limitations to every meta-analysis. And I really don't like meta-analyses, especially in cardiogenic shock these days. But nevertheless, those two papers do show some benefit across the board of unloading. So anyway, the point is, I just want to make is I don't think that we know the number of patients who need it, quote unquote, and I don't think we know the number of patients who benefit from it, the percentages.
Well, I'm glad I offended you, because that was the purpose of the meta-analysis, was to show that a big gamish, retrospectively reviewed, uncontrolled on patients. You don't know what the circumstances on which they put them on. You don't know exactly the type of ECMO. Remember, I said Schaff recommends a variation of 10 different styles and combinations and permutations of ECMO. So you're absolutely right. That's number one. Number two is 20% is the current thinking among the consensus panels and the experts. That's not exactly what the literature shows. What the literature shows is you'll have Joe Blow, who's an enthusiast, and he'll do it 60% of the time, and Joe Schmidt, who's not an enthusiast, it does it 5% of the time. You put them together and you get to 20%, right?
Yeah, I think that we're agreeing with each other.
So,
I think that's the best I can do, is get an agreement.
but the bottom line is, we know that VA ECMO alone has the potential to add to the afterload of the heart. And this is a heart that's failing at some level, either from hypoxia or from cardiogenic origins. So yes, you have to be mindful of the fact that the heart may need to be unloaded. And yes, an intra-aortic balloon pump may do it if it's adequate. But we can't show that with the literature.
Okay,
Dan, can you define me, please, what's degree of unloading you want?
I'm sorry, say?
Definition of the degree of LV unloading. We don't have definition for that.
Right, but there are...
How you are going to unload? What's your understanding of unloading of left ventricle?
I think there are...
It's the left... Yeah, well,
yeah.
It's the wedge pressure below certain level. It's a distension of the heart. How you are going to define the clinically meaningful unloading of those patients? In our experience, we have less than 10% of the patient requires more than additional tool to unload the left ventricle. This defined by wedge pressure below, pulmonary artery diastolic pressure below 22, or wedge pressure below 20. That's what we're looking for, and opening of the aortic valve.
Yeah.
That's
Yeah, we've had this discussions. We've had these discussions over the years, you and I. So I think in part it also depends on the patients that present to your institution. We get patients who are failing ECMO. So we have a bias of patients that are already on ECMO, on a balloon with a high wedge pressure. So those are patients that need to be transitioned. So we have a bias sampling. So I'm actually saying that we don't know the actual percentage of patients who need it, but it should be monitored and look for indexes such as wedge pressure, such as aortic valve opening, pulmonary edema, et cetera. I think we have time for one more or two more comments from the panel.
I think the LV unloading concept is a really important one. And when we look at these data that's been published, when I look at these patients, I think of two patients in my mind. The ones that were either in a balloon or an Impella, and they started to deteriorate, and the ECMO was put in, and the Impella was left in at P2 as a vent. And those are probably a much sicker patient population than those that were up front, put on both ECMO and either an Impella or septostomy if there's LV thrombus. And even amongst those, there's the early venters and then there's the late venters. So I think the benefit is still truly understated, and in terms of how much hemodynamic benefit these patients can gather. And amongst those that get vented late and those that get vented later.
And that was one of the points of the latest meta-analysis, was early venting, regardless of the wedge pressure that meta-analysis showed that early venting, meaning less than 12 hours, benefited compared to later than 12 hours.
I think if you're looking for LV recovery, upfront, if you're coming with AMI shock and you've revascularized and the LV diastolic pressure is elevated, I think upfront we should go for it because LV distension will kill that ventricle. So if it's going to be upfront for recovery, I think we should be aggressive. If it's end-stage heart failure where they're just burnt out, you're going to go for MCS, durable, or transplant, then it doesn't make that much difference because you already made that decision.
Except as long as the lungs are okay.
I'm really thrilled to hear you guys arguing about unloading the left ventricle because that means you're already on ECMO. So congratulations. Keep it up.
It's interesting.
One last comment.
If you can take the point of view that LV unloading as a general strategy is required, and then you can take a specific tailored approach where you look for elements of congestion, a lack of pulsatility on the arterial waveform, lack of aortic valve opening and dilation. These are patients that we know for sure do terribly. It's a very interesting question. Is the degree of benefit for general strategy of unloading specific to those high-risk patients, or is it beneficial in general? And I just, as a hemodynamicist, what are you accomplishing if you're not congested and you unload?
I have not advocated for that. I think that it should be.
Yeah, so I'm not saying you have. Is there a benefit to that?
Well, it depends on, in the basic literature, there are, evidence of molecular changes that are due to unloading that activate protective pathways in the setting of myocardial ischemia. So those have yet to be fully proven in the setting of human pathophysiology. But unloading potentially is not only about wedge pressure and diastolic pressure, but there may be some other aspects that are beneficial for myocardial preservation, yet to be proven in the clinical setting.
But it seems at a minimum we should look for those high-risk criteria in patients who are on ECMO and get them the venting because we know for sure that they do poorly.
Yeah. Okay, I think we have
So
to
you
move
heard
on.
it here first. You put everybody who's really sick on ECMO, and then you argue like hell whether to unload them.
Well, we'll talk about that later.